اهلا بيكم. انا هاني نعيم. الحلقه دي متصوره في مطار بوخارست. احنا لسه مخلصين المؤتمر الجمعيه الاوروبيه لالتهاب الاعصاب السكري النوبات، وقابلت صديقي الاستاذ الدكتور هاندريان سوران. قابلته في مطار بوخارست وطلبت منه ان احنا نصور حلقه، والراجل كتر خيره قال لي وماله. ولي Hello, Professor.
Hello, Hani.
Would you please introduce yourself again to the people of Egypt?
Sure. Hello, people of Egypt. I'm Haaندريان Soran. I'm a professor of medicine and consultant physician and endocrinologist based in Manchester, United Kingdom.
Okay. And your specialty is?
I'm a endocrinologist with a subspecializing in lipidology and cardiovascular risk. That's from a clinical and research, and clinically I'm also interested in obesity and calcium and bone metabolism.
Okay, wonderful. So, in the last episode, we were talking about the safety of lipid-lowering drugs. We spoke about statins, and then we spoke about the injections. Okay. Now, in this episode, we'd like to cover the two remaining drugs, ezetimibe and icosapent ethyl. Okay, what do you have to say about these drugs?
Yeah, ezetimibe is a cholesterol-lowering drug. It lowers cholesterol by preventing or reducing cholesterol absorption in the bowel, and it is a good add-on to background statin treatment. It lowers cholesterol by up to 18 to 20% on the top of statins, and there is evidence that adding ezetimibe to statins compared with statin only, it gives further reduction and further benefit in terms of reducing heart attacks and strokes or cardiovascular events. Icosapent ethyl is a purified omega-3 fatty acid, or in lay language, fish oil. Oh, sorry.
So there are two types of omega-3, EPA and DHA. Okay, EPA is the good part. This is only present in therapeutic concentrations in icosapent ethyl, internationally known as Vascepa, however you say it. Okay. It's present in Egypt under the trade names icosapent and ixidolip. Okay. Please continue. And not the normal omega-3 tablets.
Yeah. So
We'll get to the normal omega-3 tablets in a bit. Okay.
Over-the-counter one.
Yes.
Yeah. So the pharmacologically produced one, Vascepa, it's icosapent ethyl. It's purified. It is basically produced pharmacologically and very tightly controlled. And there is evidence that prescribing or adding Vascepa to ongoing background statin therapy in patients with high risk for cardiovascular events, like those who already had an event, or patients with diabetes, it's beneficial if they have high triglyceride, and it reduces risk of future cardiovascular events by up to 24-25%.
That's really good, by the way.
It is, yeah, it is, especially in high patient risk.
High risk. Okay. And what about the over-counter omega-3, which is supposed to improve your memory, protect you from heart attacks, what else? Make you in good health, probably give you a good child, okay, and whatever you want. What do you have to say about them?
The benefits I mentioned strictly applies to Vascepa. It doesn't apply to over-the-counter preparations of omega-3 fatty acids. The reason is that these over-the-counter prepared products, they are not pharmacologically produced, they are not purified, and in fact, in one study when they analyzed its content...
It wasn't just a study, it was a mega trial. The strength trial.
No, not. I'm talking about a study where it looked or analyzed the
analyze the commercial tablets. Yes.
Over the counter. Actually, it contains saturated fatty acid, which is a bad saturated fat, which is a bad fat, and it contains oxidized fat, which is a bad fat. So we cannot apply the evidence we have for Vascepa to over-the-counter fatty acids,
Okay.
omega-3 fatty acid capsules. In fact, if anything, they may harm.
Okay.
So I never recommend over-the-counter available omega-3 fatty acid capsules or preparations.
And this year, we have a frank recommendation from the European Society of Cardiology not to prescribe omega-3.
Yeah, over-the-counter one, yeah.
Yeah, it's a frank recommendation
Yes.
for the very first time. Okay, speaking of the STRENGTH trial, which I just mentioned a while ago, this was a mega trial, 14,000, 15,000, 13,000, something like that, a very large number.
It's a large number.
Okay,
And it used a combination of EPA and DHA,
which is omega-3.
omega-3, yeah, and
Okay.
basically the results was negative, so there were no benefit.
Okay,
So that's
But-
why
but something happened.
Which
The
is-
AF higher, significantly increased prevalence of atrial fibrillation.
yeah, that's it's with the use of omega-3, whether it's Vascepa or the product used in strength, DHA plus EPA, there is a slight increase in risk of atrial fibrillation.
Okay, which is a bad thing.
Yeah,
Of course.
it is one of the side effects.
Okay, so next question. What about the new hyper LPA syndrome? What about apolipoprotein B or ApoB as we call it? So first, what's LPA or lipoprotein little a, and what's the difference between LPA little a and big A or capital A?
Lipoprotein A with capital, or we call it apolipoprotein A.
Okay,
It is a protein on HDL cholesterol, which in lay language is the good cholesterol. So apolipoprotein A is basically inversely associated with risk, cardiovascular risk. And this is very different from lipoprotein little a.
okay,
Lipoprotein little a is its structure is similar to an LDL particle, but a little a is attached to it.
okay.
And this one is atherogenic, like high levels is bad, like LDL. So that's the difference between the two, and we shouldn't confuse the two.
Okay, and the current recommendation is everyone should have their lipoprotein little a checked at least once in their lifetime.
That's a European Atherosclerosis and European Society for Cardiology recommendation.
Okay,
That they recommend checking lipoprotein little a. I think it's a good idea to check it, especially in patients with high risk, to stratify the risk factor.
I check it in all my patients are diabetic anyway, so I check it in all my patients. Okay, and some of them actually come out with very high numbers. What should I do about it?
Yeah, at the moment we don't have specific treatments licensed in clinical use to lower lipoprotein little a. But what we can do if lipoprotein little a is high, we should be more proactive and aggressive with lowering LDL cholesterol. So, because this may blunt the harmful effect of high lipoprotein little a, whether we can lower lipoprotein little a or not, LP little a, and whether that is beneficial or not, we need to wait for the clinical trials outcome, which is due next year or 2027.
Okay, well, we have several things in the pipeline, pelicarson.
Yeah, and we have three. I think the first one is due to report either next year or the year after. And hopefully we will know by then whether we know it is harmful. High levels is associated with increased cardiovascular risk. And after the report of these trials, hopefully we will know that whether lowering it is useful and beneficial. And I expect the trials would be positive, but we need to wait for
I
the
also
results.
expect so.
Yeah.
Speaking of, when I get a patient with hyper LPA and with an actual complication, okay, I do something which is totally off the book. It works. I give a PCSK9 inhibitor. Okay, because it says it does decrease it up to 30 or 40%. Okay, it works with some people, it doesn't with others. What can you say about that?
I mean, adding a PCSK9 monoclonal antibody to background statin therapy in these patients is lowers LDL cholesterol by 50% and Lp(a)
Yes.
by anything between 20 and 30%. And lowering LDL cholesterol by 50% is very
Beneficial,
useful.
yes.
Very useful, and it may at least blunt or reduce the risk from high Lp(a). And lowering Lp(a), although we don't have a randomized trial, but lowering Lp(a), again, that's
Should be something good.
Yeah, I expect this also beneficial. And there is some ad hoc analysis which attributes some of the benefits from these injectable medications to lowering Lp(a).
We really need to wait for the outcome, of course. But adding, as you mentioned, adding an injectable to background statin therapy in very high-risk patients in high Lp(a) is reasonable because at least they get benefits from that 50% reduction in LDL cholesterol.
Okay. Now, that is very, very useful. Okay. So, to sum it up, we went through the other non-statin medications, which, we forgot the fibrates. Yeah. What do you, it is looking good, and it's not the statin. Okay. Will you tell us something about fibrates?
Fibrates is, the data is more difficult to interpret and it is more controversial. They quite large trials. If you take the individual trials, they did not achieve the primary outcome. But it's put this
What are the primary out?
cardiovascular event.
Okay, so it didn't decrease the cardiovascular events.
Yeah, but if you put all of these trials in patients and you look specifically in patients with high triglyceride and low HDL, then it gives some signals and it gives a positive results in terms of cardiovascular events. That's in patients with high triglyceride and low HDL. However, the controversy, the complication comes after the result of thumbnail study, which we did and we reported in the Journal of Mass. In patients with well-controlled LDL cholesterol below 70 milligram per deciliter, already on a statin, adding a fibrate did not benefit. But this is in patients with well-controlled LDL cholesterol.
So basically, they didn't need it.
They didn't benefit.
No, they didn't need it, so that's why they didn't benefit.
So I wouldn't, if a patient's LDL cholesterol is well controlled, below 70 milligram per deciliter, because there is no need to add a fibrate, because there is no abuse problem. If they have a higher LDL cholesterol, we don't know. So it is better to focus on LDL cholesterol lowering because that's where the azapan-6.
Okay. Is there anything you would like to add from the subject?
There is no evidence that they increase cancer signals for statins, and there is extensive evidence that they reduce incidence of morbid arteries, atherosclerosis, and cardiovascular deaths.
Okay. Are they useful for peripheral arterial disease?
Yes, absolutely, especially evolocumab. Data from Poria showed that people with peripheral artery disease, they even benefited more. So that's than the general population of the study. So you need to treat less patients to prevent one event. So number needed to treat was never indicated.
Okay, now the word number needed to treat means how many people do I have to treat for this to prevent or gain an event? Okay, so the lower the number needed to treat means the more effective the drug is. Okay, so basically we had a very low number needed to treat in the regularly.
Yeah, exactly. If you look at 4-year overall population, those with diabetes number needed to treat was lower, and those with peripheral artery disease had the lowest number needed to treat, which is good. The lower the number needed to treat means the better reason.
Okay, and so let's wrap it up. What we covered today was first we went through other non-statin lipid-lowering drugs with the HOSA. Then we went through the high-fructose bone, which is the future.
Okay, will you please give me a word on apolipoprotein B?
Apolipoprotein B is the main protein on LDL pathway, and heterogenic or harmful particle. Again, the same applies. The lower is the better.
Okay. And should we measure it?
In some, if costing is not an issue, but that's extensive to measure. I like it to me.
That's expensive.
Yeah. Is it not? Yeah. For us, it's compared with lipid profile in UK. The cost is probably doubles if you measure it. But if cost is not an issue, whatever. If cost is not an issue, I really like to measure it in everyone. If cost is an issue, maybe we just measure it in certain subgroup of patients in particular those with high risk or with hypercardiacity.
Okay. And after that, we went to the hyperalpacin rule. Now we have a word on FOD. And we have spoken about the benefits of lipid lowering in peripheral arterial disease. And basically, we have, as said several times, these are very safe books, whatever they are. And when we actually lower cholesterol, the lower the better. When we lower it massively, the clogging of the artery reverses and we have a wider artery.
I just want to ask something. Maybe perhaps I can ask you a question.
Yes.
And for me and for you, how many times you saw patient admitted to hospital because of lipid-lowering medication side effects compared to
in my entire career, okay, and I have seen several 100,000 patients on different medications. I have seen I admitted 2 patients, okay, and one was treated on an outpatient basis, and these were the only 3. I'd say probably the incidence is 1 per 100 college.
And with this, we have come to the end of our episode. I really would like to thank you for your time, Hadrian, and I wish you a safe flight back home. Okay, and it was a pleasure meeting you today at the airport. I hope you have enjoyed this as much as I did.
I did, and thank you very much, Hany, and safe journey to you as well.
Okay, thank you so much.
Thank you.